So 3 years from now, in my world, a lot of people will have a smartwatch and they'll be using it just like your car has a dashboard.
Yeah.
So you'll be using it to measure the health of, you in the case of the smartwatch, your car. You wouldn't imagine driving a car without a dashboard. Yet here we are running around, many of us without anything to measure our health except our internal sensors, which are not so accurate.
Hi everyone, it's Doc M, your champion of well-being, and welcome to another episode of The Edge. Now, if you thought that you're someone who likes looking at your health data and wearing your wearable like I am today, and you're at the cutting edge of health data, let me tell you that actually there are some very, very smart people out there that are doing some incredible things with it. And my guest today is arguably the world's leading thought expert in this particular area. So I'm really excited that he agreed to join us and really excited by the conversation we're going to be having with one another over the next hour. My guest today is Professor Michael Snyder. He is the Professor, Department of Genetics at Stanford University School of Medicine and the Director at Stanford Center of Genomics and Personalized Medicine. He's a recipient of the 2009 Genetic Society of America George Beadle Award, and he's also the co-founder of many companies. And I'm really excited to get into some of those with him today. Many companies that take the science and academia and actually bring the business case so that it's very applicable and pragmatic for us as individuals to use those tools and that science as well. He's the author of the books Genomics and Personalized Medicine, What Everyone Needs to Know, and that's precisely what everyone will get to know today. Professor Michael Snyder, welcome to The Edge.
Thanks for having me.
Wonderful. So I always like to begin, because we're doing this in lockdown, by asking our guests, where is it that you're signing in from today?
Well, I'm at Stanford, California. I live on campus, believe it or not. My house is here, and I'm in an office that used to be my wife's till I took it over when the pandemic hit.
All right. So where's she gone then?
She's gone up to an attic, if you will. It's a little more private, and she likes that.
All right, fantastic, fantastic. I've begun by asking folks about their love of health data, and I'm sure a lot of our viewers are that way. I'm proud because I've got one device on my wrist, I've got one device on my tricep measuring my glucose and these things, which I get sort of excited about. But you take it one level further. Tell us a little bit about your healthy obsession with data and what exactly you do to track yourself.
Sure. So as you point out, I'm very obsessed. I'm all about a believer that big data is important for understanding our health and managing our health. And so it really started with just the idea that medicine is broken. We really measure so very few things when you go to a doctor's office. And actually, you don't go to a doctor's office very often when you are healthy. You tend to go there when you're ill. Yeah. And our concept is that we should really be following people while they're healthy, understand their healthy baseline, and then see, catch disease early before symptoms occur. And so a number of years ago, it's actually 11 now, a little over 11, we set up this very deep data profiling where we actually sequence people's DNA, and then we take as many molecular measurements as possible using very advanced technology. So we'll measure all the RNA and proteins and metabolites in your blood and urine. We'll also measure your microbiome. And then we do a ton with wearables these days. We started when these fitness trackers came out. We realized these are more than just fitness trackers. These actually are physiological monitors that can follow your health. And so I use quite a few of these devices, as you point out. I use 8 devices every day. So
yeah. And I love this saying, I've heard you say this, that you can't get enough data. And I've always lived from this opinion that you can't treat if you can't measure. So, I think it just speaks testaments in terms of how much you can do. And what have you, discovered at a high level amongst these types of experiments? So we're going to get into some of the self-diagnoses that you've made for yourself later on. But, and the group level, what are some of the things that you're beginning to see, which are advantages?
Yeah, so we've been doing this on a group of 109 people for about 8 years now, for me, 11 years. And we've discovered just from the first little over 3 years of data from those 109 people, 49 of them had a major health discovery. Like we caught someone with early lymphoma, 2 people with pre-cancers, 2 people with serious heart issues. It's a wide range of things And what was powerful about it was no one technology did it. Genome sequencing predicted risk. And that led to the discovery of someone who had a serious heart issue, another person who had early thyroid cancer, which was predicted to some extent from her DNA. And then we caught these things early, and the people have been managed properly. And so in other cases, it was imaging, and other cases, it was some of the molecular measurements. In a few cases, it was even the wearables that told something was up. And in all cases, it was before there were symptoms. So we caught these conditions, if you will, by these various big data measurements. And that turned out in some cases to be life-saving. So and we've now spun off a company, to your earlier comment, to actually be able to do this at scale. And it's expensive now, but as we go forward, we're pretty confident we'll be able to get the prices to drop.
Yeah, and this is quite often one of the many sort of criticisms of this. And I'm sure a lot of my medical colleagues who are watching this will have faced the situation where their patient may have come in having worn a wearable device, which has flagged off an abnormal heart rhythm or an atrial fibrillation, etc. And there's sometimes people think that there's just too much information being made available in the hands of people who don't know what to do with that. So how are you solving for that as well? How are you making the clinical decision-making tree easier, both for the patient, but also for the clinician?
Well, that'll be really important. There's no question. But right now, we're just trying to collect data and understand what data is most valuable and what data can tell you. So, for example, in the case of the smartwatches, it's early days, no question. And I'm sure we'll get into this, but we think you can pick up when somebody's getting ill from an infectious disease prior to symptoms, which is a big deal. But other things will trigger that, for example, as well. And I think if you can educate people, yes, these signals are going off. It may alert you. It doesn't guarantee there's a problem, but in some cases it is life-saving. Like in some of the people with smartwatches have discovered heart defects because they saw abnormal signals. So I think it is early days. We'll get better at it. So we'll be able to better say this signal says you do have a heart defect. This one says you're stressed. And so as we get more data and better types of data, I think we'll get more accurate in these. So, but in a sense, it's no different from what's happening now. For example, if you see your child is a little lethargic, the first thing you do is you put a thermometer in their mouth, and they may or may not have a temperature suggestive of an illness. So we use these measurements to be able to better guide us into what we think is going on. And that's how it should be perceived. Doesn't guarantee there's a problem.
Yeah. And you've been doing this now for so long, right? 11 years just through this one study of measuring folks.
I have 2 petabytes of data. Two petabytes of data.
2 petabytes of data just on yourself.
On me.
Oh, wow. Okay. All right. So, we're all familiar with Moore's law and the sort of exponentially declining curve of things getting easier and smaller. In the last decade that you've been collecting this on yourself, how true has that been? How much easier is it now versus when you started this off? And I know, Bill Gates has this incredible saying, we always underestimate what we can do in 10 years and overestimate what we can do in 1 year. But if you were looking forward, say for 3 or 4 years, what do you think will be happening, and how accessible might this be?
So in certain areas of what we do, we've well exceeded Moore's law.
Right.
Genome sequencing has dropped 5 orders of magnitude in the last decade, which is way, way beyond Moore's law. And that's true of a lot of these areas, the ability to measure things with smartwatches, for example. Well, first of all, it didn't even exist 10 years ago. And so I would, most of the areas we're in are going much, much faster. And I think that's going to continue for the next few years. And so we are getting better and better. This is early days. And so the number of measurements you make from a smartwatch is just going to go up and up. And I'm confident in 3 years we'll be measuring much, much more than we do now in terms of physiology, in terms of biochemical measurements. And I think the pandemic has helped make people very aware of their health and their family's health. And so I think that's, driven a whole new level of acuteness that people are now very engaged with trying to understand their health. And I think there's also a lot of interest in remote sampling and measurements. And so I think that's also going to drive a lot of this. So 3 years from now, in my world, a lot of people will have a smartwatch and they'll be using it just like your car has a dashboard.
Yeah.
So you'll be using it to measure the health of, you in the case of the smartwatch, your car. You wouldn't imagine driving a car without a dashboard. Yet here we are running around, many of us, without anything to measure our health except our internal sensors, which are not so accurate.
It's very, very interesting indeed. So let's look at some of these very specific use cases, devices, and the areas of health that are immediately applicable. And I think one of the biggest things, particularly for me sitting out of India, is diabetes. Right, we're the diabetic capital of the world. I was reading some of the literature from the US with regard to the percentage of people, up to 35% of people are pre-diabetic, something like 8, 9, 10% of people have diabetes, 35, 40% of people are pre-diabetic. But what was most staggering was that almost 90% of the pre-diabetics don't even know that they have pre-diabetes, right? Now,
Absolutely.
We've waited for a patient to come in with a dry mouth, with urinary frequency, or some of the other common symptoms of diabetes. My colleague would ask, have you got a family history of it? Let's get a urine sample. Let's maybe check your HbA1c. That's typically how that journey would go in a doctor's office. But now with these devices, before you get the diagnosis, whether you're pre-diabetic or post-diabetic, in fact, let's just assume it's a diabetic spectrum, because, it's probably 40, 50 different diseases in there, to be fair. Tell us about the role of the continuous glucose monitor and how you've used it on yourself as well as your folks that you've been studying.
Yeah, I think it's going to be revolutionary. But to back up a little bit, just to let people know, I'm type 2 diabetic myself.
Right.
And it was actually predicted from my genome sequence of all things. And that's how I discovered I was at high risk for diabetes. And then as I was monitoring myself, I did in fact become diabetic after a nasty viral infection. This is before COVID, it was a different virus. And so I did get it under control, though it is back now. And I'm a very unusual diabetic, although not so unusual for India, where there's a lot of thin diabetics. And that's what I am. I'm not overweight. So, and as you say, it's an endemic worse than COVID, and it's only getting worse. And I think these new continuous glucose monitors have a chance to really be transformative, because if you put one of these on you, and you can see what they do. They show exactly what food spikes you. And the reason they're powerful is, first of all, we're all different. The foods that spike you are going to be different than the foods that spike me, will be different from the food that spikes the next person. Some people spike to bananas, other people to grapes, some people to bread, some to pasta. It's all over the map. And your microbiome, so your gut microbes, are at least one component of that. It's not the whole story, but it's one component. And so actually these devices, they show you in real time what foods spike you. And that's really, really powerful. And a lot of it in hindsight is obvious. For example, for me, I ate a pork sandwich and my glucose went through the roof. And, I was showing this to a friend of mine who said, well, of course, Mike, everybody knows pork sandwiches have sugar in them. And I said, duh, I had no idea. And that was true. I talked to a New York Times reporter. He thought he was eating healthy, and salmon and over lettuce. And his sugar spiked through the roof after he ate that. And then he realized he was putting balsam vinegar on top of his salad, which had sugar in it. And that was what was triggering it. So these simple little things that in hindsight are obvious, the glucose monitor picks up. Yeah. And so it teaches you, don't put the balsam vinegar on your salad and you won't spike your glucose. Yeah. And so for me, it was really transformative. It's true. And here's another case where we spun off a company called January AI that basically does that. It goes much, much further. We actually have, we can tell you the glycemic index of all the food you're eating. And so that's a really useful tool too. But you can see what's spiking you. You can see how to mitigate that. It tries to teach you, if you walk after you eat a meal, you can suppress that spike. I know it sounds simple, but most people don't do that. And yet, again, this will teach you to do that. So I encourage everyone to try these. First of all, you'll discover you may have glucose dysregulation. You didn't realize that was one of the big discoveries we made. We started putting these on normal people, and suddenly we discovered a lot of them were spiking through the roof. And as you point out, 9 out of 10 pre-diabetics have no idea. Yeah. And so first of all, it shows you you're a spiker. And then second, they teach you what not to do. They're over the counter in Europe. In the US, you still need a physician to be able to order these, unfortunately. But anyway, they're powerful devices, and I do think they're going to change, how people manage their health, I hope, and their eating habits, and hopefully prevent diabetes, at least push it off for a number of years.
Yeah. And for people who are wondering why we are being so obsessive with the spike, I'll just remind you that when you're getting your blood test done at the doctor's clinic, etc., they're typically asking you to do two things. It's either a fasting glucose, which is a on-the-spot measurement of how high your sugar level is, hopefully in a fasted state, or they're doing an HbA1c, which is a glycosylated hemoglobin measurement, which is effectively trying to know what is your percentage of red blood cells, which have these tiny sugar molecules attached to it over a 3-month period, which is how long the red blood cells survive. And the reason why Professor Michael is suggesting the spikes are important is you may actually have a pretty flat level of HbA1c over the 3 months. But actually what's happening is every time after a meal, you're having this massive spike, which then drops down again, but it spikes back up again and then drops down. And it's this effect, this spiking effect, which can actually lead to a lot of long-term damage in different parts of the body, because your insulin level then dysregulates itself and it leads to a whole host of other things. Prof, it would be interesting if you could describe a little bit about what the actual CGM device is. Some people may know that it looks like a 10 pence coin, and other people may know that you attach it to your tricep. But can you explain a little bit about what exactly it is, what is it measuring, and a little bit about how it works and how people can use that information practically?
Yeah, there are two leading devices out there. More will be coming, I'm sure. And there's one that sits on your shoulder, as you point out. There's one that you actually can have on your stomach, which is the one I use from Dexcom. The other one's from Abbott. And basically what they do is they have a little sensor that pokes into your skin, if you will. It's a little bit like a TB test, although it sits there permanently for 2 weeks. Yeah. And basically what it does is it's sampling a little bit of what's called your interstitial fluid. So this fluid that's just under your skin, and it's a biochemical reaction, glucose oxidase reaction that gets measured. And the bottom line is it's measuring your glucose levels every 5 minutes. And so it gives a measurement, and it'll do that 24/7. So it'll do it for 2 weeks straight. So you'll see after every meal or snack or whenever you eat or any activity, even exercise, you will see your glucose levels go up. And there are certain foods that spike everyone. White rice, for example, is a notorious spiker. It turns out cornflakes and milk is a very spiky and very popular breakfast in the United States. And I personally think it probably should be outlawed because it is so nasty. There's a lot of foods like that people are routinely eating. And again, the device can measure that, and it sends a signal right back to your smartphone. So you can see either in real time. For the one device, you have to swipe to see, but otherwise you can just see what's going on. And so again, they can teach you exactly what foods are causing your glucose to go out of control. You can show how to mitigate it if you, as I say, walk after a meal. You actually can even see if certain foods will suppress other foods that will spike you. And again, a lot of that's at a personal level. One of the things I discovered is that, and this is somewhat known, is that wine actually suppresses spikes. So when I have wine for dinner, it'll suppress my glucose spikes. So you can learn all these things, and hopefully you can then use that information to better manage your glucose levels. And as I say, try to at least push off, if not lower your glucose levels, push off diabetes, and again, better manage your health.
Yeah, absolutely. I personally found apple cider vinegar to be quite good at blunting the glycemic spikes that I would get. And it's not just food, right? It's also things like how well you've slept during the night. That can have a big influence on your sugar levels the next day, and other things like the type of exercise and how much exercise you're doing and stuff.
Yeah, believe it or not, it turns out weightlifting, so strength training, actually also causes you break down a storage molecule called storage molecule called glycogen into glucose, and that'll spike it. Now don't worry about that one. That's a healthy phenomenon. So I wouldn't panic over that. But the food ones you should be very, watchful of.
Yeah. And last point on this before we move on, I'll just remind people that if you've watched the episode that I did with John Gloucester, the sports physiotherapist for the Indian cricket team now at the Rajasthan Royals, he was sharing information of how 35% of his athletes, and these, remember, are world-class athletes, young, people at the cutting edge of their sporting career, they were found to be pre-diabetic. So it's not just the folks who we think about, the couch potatoes or the sluggish individuals. It's literally this disease, this epidemic, as Michael was talking about, is everywhere. And each of us should get tested and should ensure that we're being really observant about our blood levels, because it can cause a lot of long-term damage.
I would say absolutely. And also, even if the damage isn't evident now, if they let it continue, 20 years later, that's when the heart problems show up and things like that. So absolutely.
Yeah. So great segue, talking about the heart. Another big indicator that a lot of us use is resting heart rate variability, and now increasingly so because of COVID, having pulse oximeters at home. And a lot of the devices now, the new Apple Watch and some of the other Fitbits also measure your pulse oximetry. You had a very interesting self-diagnosis using these 2 or 3 tools. Do you want to talk about that first, and then we can talk about the COVID work that you're doing?
Absolutely. So we got involved in this area again through this concept of big data measurements on people. And so 8 years ago, I think it was, before the Apple Watch was out, the Fitbit did exist. We saw people using these as fitness trackers, and we said, well, gosh, these are pretty good physiological monitors. They're measuring your heart rate 24/7. So we put them on this group of people, myself included, and we just started watching what goes on. And you discover some cute things. Your blood oxygen drops on airline flights and your heart rate goes up. It turns out most people don't know that. Pilots know. Most flight attendants don't know that. And that's because they reduce the air pressure in the cabin, and so the blood oxygen is lower. So then as we were using these, and I was doing all this and learning these things, at one point, I discovered the bottom line is my Lyme disease. I detected my Lyme disease from a pulse oximeter and a smartwatch. And the story behind that was I had been helping my brother put up fences in Massachusetts, where Lyme disease is very common. And then 2 weeks later, I was flying to Norway. And on this last flight from Frankfurt to Oslo, it turns out that my blood oxygen dropped abnormally low. You can tell I measure myself all the time. And it was way lower than usual. And not only that, it didn't come back, and my heart rate was up as well. I later learned my skin temperature was up, which is something you can also measure from a smartwatch.
Right.
And so I knew something was up because, and again, when we landed, the heart rate was still high. And so I knew something was up. Later, I got a low-grade fever that went off and on. So I went to a physician. I warned him it might be Lyme because of that 2-week period there.
And Lyme disease, folks, is a tick-borne infectious disease. So it's spread by a tick bite, which is why Michael was talking about putting up fences. That's the important part of this history. Yeah.
That's right. Yeah. Sorry. Thank you for that. Yeah. So and so it's a certain kind of bacteria that actually causes us. And so the physician drew blood, saw that my immune system was off, and basically say, yep, you've got a bacterial infection. And he wanted me to take penicillin. And I said, no, I need doxycycline, which is what you take for Lyme disease. And it was a little tense for a few moments there, but he did give in. And so he gave in, gave me the doxycycline, cleared it up right away. You do take it 2 weeks. And when I got back, I got tested. And sure enough, I was Lyme positive in terms of having antibodies to it. I even had some antigens around as well. And it's very controlled because 3 days before I left, I'd given blood because I do measure myself a lot. Yeah. And I was negative then. So I'd seroconverted during this time. So it's very, very clear. So the bottom line is I could first figure out when I got Lyme before I had symptoms from a smartwatch and a pulse oximeter. And so we looked at all the data I had at that time. I had 2 years of data. It was 2015. Yeah. And we looked over that, and there were 4 times when my heart rate and skin temperature were off. They went up. And all four of those times, it turns out I was ill. The Lyme disease was one. There were two other viral infections. And what was really cool was there's a fourth time where I did not report any symptoms, but I was in fact ill because I had high what's called C-reactive protein. Right. It's a sign that you've got an illness. So it's just as high as the other times, but as asymptomatic. Mm-hmm. So every single time I was ill, actually, my heart rate, my resting heart rate went up, as did my skin temperature. And that was all retrospective. So we wrote an algorithm, we call it change of heart. It didn't work so well for skin temperature, but it worked well for resting heart rate, where we could see your heart rate jump up from a background, from a stable baseline. And it worked well on all the 4 times I was ill retrospectively. We looked at 3 other people who were ill, one of whom got sick twice. And same thing, every time it picked up this jump in heart rate prior to symptom onset. Yeah. So we published that work in 2017. People thought that was amusing. That's nice. Okay, great. And then we continued to improve the algorithms. And then, of course, the pandemic hit. We were also building a system to scale this because it's tricky to do this. We actually want to do this for the entire planet. We're thinking very big on this one. And so when the pandemic hit, as you might imagine, we just ramped this up full blast. And so I have a team of 25 people who quickly worked on this. We first showed that, in fact, yes, you can see this jump up in heart rate when people get COVID. We quickly launched a study. I'd love all the listeners to join our study. It's innovations.stanford.edu/wearables. So innovations.
We'll put that in the show notes as well. Yeah.
Fantastic. Okay. So anyway, because we are trying to get as many participants, we want to get this working as well as possible. Yeah. So first, what we did was we had 32 people who had a smartwatch and had COVID and were wearing a time and had a diagnosis and a symptom date. And we could show that for 80% of those, 26 of the 32, we could see this jump up in heart rate. And our very first case was so striking. It was kind of interesting. You could see 9.5 days before symptoms, you'd see a very clear signal of their heart rate jumping up. 9.5 So it was 9.5 days. Yeah. And it turns out the median is 4 days. We can pick that up 4 days prior to symptoms. Yeah. So people are presumably running around spreading this without knowing. So we and I should point out, it's not specific for COVID. That is to say, other illnesses can trigger this, as can stress, as can, to be honest, other things. If you run a marathon, your heart rate will stay elevated for several days. Go to high altitude can have that effect too. But their real signals are picking up this shift in resting heart rate. And so we've now set up a real-time detection system, and it's working. That is to say, we will send an alert when we detect a jump up in your resting heart rate over your normal baseline. So we're grabbing your baseline, hour by hour. And then if we see this jump up over a number of hours that's statistically significant, we'll ping you a red alert. And it's working. 78% of cases now, 60 some cases, we could actually detect, again, this jump up in resting heart rate prior or at the time of symptoms from a smartwatch.
Yeah. And, the reason why I was so excited when I heard this was, if you're picking it up 4 days, so even if you take a country like India, where we've had such a high percentage of people who are asymptomatic, no clinical symptoms, but it would be interesting to see if they're actually having physiological changes, and heart rate is presumably an easy signal to measure. But even in
can I add to that? It turns out we had 10 cases of asymptomatic, and we picked it up every time.
Fantastic. Yeah. And
so it worked. Yeah.
The other element is there is this prodromal number of days, typically 4 or 5 days, where we say that virus is incubating itself before symptoms first begin. But people are shedding the virus. They're transmitting the virus. So if you're able to pick this up 4 days before, one could easily do a rapid antigen test at that point and figure out if someone has it or not, and then start the quarantine from that point in time, rather than wait for symptoms to occur. And goodness knows how many people they would have infected by then. Yeah, very interesting.
Absolutely. Yeah, that's the plan. So right now we're not allowed to make medical recommendations because it's a research study. We're still showing it. So our what's called institutional review board doesn't let us do that, but we will ping a red alert. And in some cases, I know people have used that information to do just what you said, to maybe not go out to dinner in one case. And it turns out they were COVID positive when they tested the next day.
Yeah. 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 Heart rate is one. The other one, which I find really interesting, is heart rate variability. And, just to share with you, when I had COVID, I had it in August of last year, and I was pretty unwell with it. It took me about 4 months to get back to health. Wow. But in the second phase of that disease, once the acute illness was over, being a runner, obviously I wanted to get back to running, and I just, like so many people, I realized how much of a toll this had on my lungs, my endurance, and my strength. I started to use the HRV data point as an interesting one to guide how much I would push my body, how much stress I could put on in terms of running, walking, etc. How have you used heart rate variability? And actually, maybe do you want to just say a few words about HRV for people who aren't familiar with it, and how maybe you've used it in some of your clinical investigations?
Yeah, so heart rate variability is well, just that. It's the variability between your pulses, your heartbeats. And it's natural that there is variability. That's a healthy heart, actually, when it shuffles a little bit. And so people have very constant heartbeats that can be a sign of illness, actually. So we use it mostly for a signal for these stresses and for viral infections and things like that. So that's where we're pushing right now. Other people have been using it to try to predict, myocardial infarctions, heart attacks. And so it can be used in all these different ways. The way we're set up, we get much higher resolution resting heart rate than heart rate variability. We want to get the high resolution heart rate variability because I think that will help us get better signals in people's health. But we don't get as strong a signal from that. And that's not because it's not important. It is, as you point out, just as important, maybe even more important than resting heart rate. But just the way we pull data in, it's harder to get access to that particular data at high resolution. But we are using it. It is a good signal. Others have shown, and we've done now as well, that heart rate variability can be a sign of infection when that shifts. So, and again, it's definitely been shown for AFib, atrial fibrillation, as well as myocardial infarctions. People will see alterations in what's called HRV for short. And so it's a great measure. It's really emerged, and that's something that's really seems to have come just over the last few years. People are beginning to appreciate how important it is.
Yeah. And for folks watching and interested in looking at their own data, the higher the number, generally the better. And actually, there's no set norm. It's very individual to who you are. But generally, the lower the number, the less the variability, the higher the stress response. And therefore, it's a sign of things which need to be looked at. I think that's a nice segue into talking about the power of the quantified self movement, because even when you were describing your experiences on the aircraft, if you had just taken the one data point in time, looking at your heart rate and maybe 80, the normal range of heart rate is anywhere between 60 to 100 as per the medical textbooks, right? So actually it gives me very little information to know what you are versus the sample size. But what you're doing is very interesting, which is you're following people themselves for a very long period of time and developing patterns around that. So why don't you talk about the power of longitudinal studies and why we should appreciate them more in the scientific world?
Yeah, you're absolutely correct. Longitudinal studies are just incredibly powerful. And it's because, as you point out, everybody has a different baseline. And medicine today pretty much ignores that. You may be taught, well, in India, it would be 37 degrees centigrade is your temperature. Here we say 98.6. First of all, it turns out that number is wrong. Here it's 97.5. So I think that's 36.4 or 5 centigrade. Okay. And but even more importantly, there's a spread. So some people, 25% of people have a temperature of 94.6. Others have 99.1. That's the 75th quartile, so 75%. And so it's just variable. Everybody has different baselines. And so if you try to compare in today's world, for example, if my healthy baseline is 94.6 and I go to a physician and they measure it at 98.6, they'll tell me I'm healthy. Which is absolutely wrong. I'm up 4 degrees. I guarantee something is off. Yeah. And so this is why it's absolutely critical critical, your healthy baseline, whether it's resting heart rate, glucose, what have you. So you can see that change when things first happen, when you first start getting ill. And so this has turned out in our study to be important over and over again. We'll see someone just recently, someone who's in our study, he saw his liver enzyme go up. It was still in the normal range, which is interesting, but his is normally very, very low. And suddenly it was right at the cusp, the high end of the cusp of the normal range. Then he got measured again, it was out of the range. So it's very clear that something happened that spiked that. So he's taken some action that, should improve his liver health. And that seems to be working. It seems to have come down back into the normal range. But had he not been measuring this, had he not known what a healthy baseline is, he never would have known to take this action. So that's proven to be true over and over again. We're all so different, whether it's our proteins, our metabolites, all our RNA. So all these molecules I talk about that we're measuring, it's all different. And this company we set up called Qbio that actually measures people. We recommend, just for starting, it's every 2 months. And that's an arbitrary number, but it's already been powerful in the sense that just in the first over 100 plus people, we caught someone with early pancreatic cancer, which almost never happens. And the way we caught it was we could see from whole body MRI, this image was changing in 6 months and something was up. And so we saw it had shifted, and that was caught. And again, that was pretty incredible. And that's been true of some other cancers as well as some heart conditions we've found. You can pick longitudinal profiling is so powerful. And in fact, in today's world, this is one of the reasons medicine's broken. Today's world in the US, it's probably the same in India, they'll tell you, don't get a whole body MRI. Because if you do a whole body MRI, you will see nodules. You'll see women will have nodules in their ovary, men will have them in their prostate, and they're not necessarily growing. We all have them there. And so the power of longitudinal profiling is actually, you could see if any growing. So the point is, we should be getting whole body MRIs, but we should be looking for the ones that are changing, not just looking for nodules. And so that's the key, look for the changes. And so that's what Qbio does. And again, not just whole body MRI, they do the molecular measurements as well, but they've caught people whose images have shifted and suggesting there was something going on in all cases before symptoms. And so this is really, really powerful. Know your baseline.
Yeah. And I think one of the reasons why that is the case, and maybe this takes us on a tangent, is that is it 90% of our health spend happens in that last year of life? And there's a fundamental mismatch, I think, between how we incentivize, for want of a better word, the practitioner or remunerate the individual versus the benefit that the patient gets in terms of the value. So we're not celebrating the prevention, we're sort of celebrating the treatment. But what you're really talking about here is creating a system that allows you to pick these things out early, because the downstream effects on a person's life, on their health span, lifespan, happiness, etc., are so much greater, so much higher, that we need to change the way we think.
100% agree. Yeah. So you want people to live long, healthy lives and then just die. Basically, that's how it should go. Extend your health span as long as possible. And there's no, especially in the US, there's no financial incentive to do that. We really do sick care, as you point out, not health care. And so we need to come up with ways to incentivize people to be healthy, to get themselves measured. And so the quantified health is a self-induced movement. But imagine if and people are talking about this, maybe your provider should, reduce your insurance payments or your costs in general. If you walk your 10,000 steps a day, if you go in and get your various vitals measured on a regular basis, do things that would actually, stimulate people to be healthy. I do think it helps to get your family involved. There's really just two things that seem to motivate most people. It's money and it's family. Right. And so if you can get either of those aligned, I think we could get people better taking care of themselves. And I think you can get employers involved in this. For example, large employers, it's in their best interest to have healthy workers. And so if they could basically stimulate people, offer maybe some of these measurements for free. And as they get simpler and simpler, that should be very, very possible, right? If you can simply go in and do a finger prick at work or somewhere else, just like we're doing for COVID now. You actually do mail-in kits. So we can do that sort of thing for people's health on a much more frequent basis. I think we can, be much better at disease prevention, or at least early disease detection, or both.
And how engaged are these stakeholders with you, right? I imagine that right now, even with a product like Qbio, it's the individual that's paying for that particular test. But
that's correct.
How, the insurance sector, the provider network, how engaged are they watching what you are doing? And when does that inflection point happen? What do we in the science world need to do to prove this business case? And then it sort of just flows from there on in.
Yeah, you have to demonstrate utility. You have to show how many examples in which you've caught something. The problem is what we're doing is broad profiling. And the numbers are still small. They'll get large as we get more and more people joining. But it does mean it's only people who can pay join now. And so what will happen is if we can show utility, yes, if you get these things checked, if you can show wearing a smartwatch, if catches 50% of heart attacks, well, then maybe your health plan will actually buy people smartwatches to show that. And they're not that expensive. So that's an easy one. And I think that's what you need to do more broadly, show each of these measurements has utility. And then hopefully they'll pick it up. But there's still a cost, benefit as well. I mean, people don't necessarily want to pay for that. And as the head of Stanford Hospital once told me, a former head, he said, Mike, nobody pays me. He meant this with good intentions. He said, really, nobody pays me unless they walk in the door, and they don't walk in the door when they're healthy. They walk in the door when they're ill. And so we've got to really change that entire financial incentive so that we are incentivizing people to be healthy. Employers, get everyone involved as much as possible. So people are watching us, but I can't say a lot of people are scared of what we're doing, especially physicians, because they think we're going to turn everybody into hypochondriacs. When we started sequencing people's genomes when they were healthy, nearly a uniform pushback, not all, but nearly all. Physicians push back on that. You should not be sequencing people's DNA because all you're going to do is lead to people getting worried about their health and getting all these expensive tests. So we did that. We sequenced a bunch of people's DNA. I found someone with a BRCA mutation who had no idea that leads you predisposed to breast cancer. 70% of people learn something important from their DNA from the sequence. And in some cases, it was life-saving. Yet physicians were worried they lead to hypochondriacs. And it did lead to an increase. There's an average of about $1,000, $700 to $1,000 US for follow-up tests. But to save lives, that's priceless in my mind. So discovering you have a BRCA mutation is a pretty important thing. It's not pleasant news to hear, but it's important news to hear.
Yeah. So I'm trying to do the maths in my head. If you alone have 2 petabytes of data on yourself and you've got 106 people and you're measuring something like 600 different metabolites and images and scans, I mean, that's a lot of data. You've interestingly begun to segregate those people into different, let's say, buckets of longevity. And you've come up with a very interesting phrase, the agiotype, if I'm pronouncing that correctly, the agiotype. Do you want to tell us a little bit more about it and the different types which exist that you found?
Yeah. So as we were profiling people over time, and again, we're unusual because we're profiling them while they're healthy. So we're profiling this cohort of 109 people for about 8 years now. This just from the first, in this case, about 4 years of data, we discovered that, first of all, most of your molecules don't change much over time when you're healthy. Even your microbiome doesn't change much, very little. There's some seasonal patterns a little bit. And then we discovered, though, there's a subset of molecules about 600 that are slowly changing over time in the cohort as a whole. And what we discovered is that different people were aging differently. I'm a pretty typical ager, so a lot of my metabolic conditions are shifting. What's called my coagulation, some of your blood markers will shift over time. But I look at the next person, it turned out their top pathway is their hypertrophic cardiomyopathy pathway. So they're a cardio ager, if you will. And so what we discovered is that we could, which is 5 measurements in 2 years, we can see how people are aging. Now, we think this is a big deal because if you walk into a drugstore, there's gazillions of supplements, all promising longevity, Elysium, what have you, and you would have no idea if they're working, right? Because you can't tell if it's working because we don't have ways of measuring this very well. And so we think what's powerful is that we can measure people. People are aging differently, and so they could actually intervene. And so what we discovered is that there's 4 major categories. I know there's more than 4. It's just that our sample size is kind of small, but we see metabolic agers, immunoagers, meaning your immune system is aging, kidney, liver. I know there's going to be cardio agers, but we only had 1 of those, and so on and so forth. So everybody's aging differently. So we think of this again, like your car, where your car, gets older and older over time, but some parts are wearing out faster than others. And so you can catch up by doing these deep molecular measurements. And then just like a car, presumably if you see, for example, your heart is going off. Well, it turns out this person had stage 2 hypertension, the cardioager. So they could basically do things to mitigate that, either through exercise. Actually, I think they're on medication now. The immunoager could eat more garlic or turmeric, coumarin, turmeric, that, stuff that's very popular in India. So there's things you could do to mitigate that. If you're a kidney ager, maybe you should be drinking more water. And so I think that's why this is powerful. They can give you clues as to what's going on. And once again, it's potentially actionable. And one of the things we discovered is that, with these agent types, there are clinical markers associated with. So the metabolic agers, for example, this one's obvious, but hemoglobin A1C, already known to go up over time, we could see actually people who reverse their agent type and their markers. And we think they've done, we know they did. For example, they just started exercising, things like that. So you could take these interventions that are beneficial.
Yeah. What is fascinating in this idea of longevity is just how much of it is in control from the basis of who you are in terms of your DNA versus how much is the influence of the environment. And, I think that is around a 75-80% influence comes from external factors, if not higher. And what I was so excited to see was, in addition to you measuring your internal physiological data, you're also measuring the exposome, the environment immediately around you, which I think is just so important, particularly as we're entering a world which has got climate crisis and pollution and all of these other things going on around us. Tell us about the device. Have you got it with you there? Do you want to show
I do, yeah. So here it is. It's an air monitor. So we're trying to measure everything that you breathe. So I know it's important to measure other things as well, like, in your food and what you drink and even maybe what you touch. This measures everything you're breathing. And there's the standard things like, humidity and temperature and something called PM 2.5. These are particulates that can get into your lung and cause issues, where there's air pollution in particular. But we're going way beyond that. And underneath this intake valve, there's a filter that captures all the particulates and the biologicals, if you will. And under that, we have a chemical absorbent. So we'll take the filter and we'll actually, using DNA sequencing, it's called, we can actually measure all the biologicals that you would actually be breathing, the bacteria, the fungus, the plants, what have you. And by plants, that's usually pollen, of course, not usually breathing entire, trees or anything. Yeah. So we can measure all that. And then from the chemicals, we'll take those and we'll use what's called a mass spectrometer and measure all the chemicals that you're breathing as well. And the results are really quite stunning. We'll discover, first of all, location is the number one driver of what you're exposed to. That's not a surprise, but it turns out season's not so far behind. So seasonal patterns are a big deal. And so on the biological, this is, again, parts of it, this isn't a surprise. We'll see lots of pollen in the spring and other things in the fall, like mushroom spores and things like this, at least in the US. So a few of this is known. Most of what we discovered had never been reported before. And I personally learned some useful things from the biological. I have mild allergies. They used to be, somewhat severe. And I always assumed it was pine because they come up in, late April. And it turns out they actually correlate better with eucalyptus. And in hindsight, that makes sense because I don't usually have them on the East Coast, whereas I do on the West Coast, which is where eucalyptus is. So I actually think I figured out my allergies just by doing this when I wasn't even trying. So that was kind of useful, I would say. And then on the chemical side, well, we're discovering there are pesticides everywhere. The substance called DEET that used to keep bugs off you, that's everywhere. Certain carcinogens are everywhere, but some locations will have a lot more than others. And so we can measure all this. And so for the first time, we see at a personal level, what is your breathing? And as you point out, you don't even know right now, probably, what you're breathing in terms of biologicals or chemicals. And nobody does because nobody measures this. And so ultimately, we want to correlate it with health. And we are doing that. We're discovering that there are some direct things. We can see what people are directly breathing and what's showing up in their blood. And it's a small fraction that we can detect, but we can see correlations between what people are breathing and what it does to the microbiome and their metabolism and things like that. And it's pretty powerful. It's pretty eye-opening.
Yeah. And is this tool for research purposes or is it being commercialized? And if it is, where can one acquire this?
Yeah, right now it's research, but stay tuned. We are going to spin off. Yeah, I'm in Silicon Valley. You can tell we spin off companies from these things, and because that's the way to get it out to the broader community. It's I think academics are really great at discovery and proof of principle, but companies are just so much better at making a really robust product that can get to the world, and that's really our plan.
Yeah.
So
fabulous. So just to recap on some of the great opportunities that people can learn more about your work and also the companies that you're doing. You mentioned the study at the beginning, which you're recruiting for. Could you give us that website again?
Yeah, innovations.stanford.edu/wearables. That's for our infectious disease study. Please join. And then we also have some continuous glucose monitoring studies as well. Some of those you have to be local for. We've spun off companies for people who would like to actually do it, but they are in the US, so I'm not sure how broad your viewership is. And that would be Qbio for sort of these deep medical measurements, and then January.ai it's for metabolic health control, the continuous glucose monitoring. That one should be able to do anywhere in the world.
Yeah. And then, of course, I remind people that in addition to all of these cool sort of wearable and data-based activities, you can also learn more about Professor's work from his book, Genomics and Personalized Medicine, and just how important this is as an area. Professor Michael Snyder, it's been such a pleasure. I literally could talk about hours with you on this, but it's been such a pleasure to have you. Thank you for being with us on The Edge.
Oh, it's been a lot of fun. Thank you.
Thank you. All right. Bye-bye, everyone.